using Poll Everywhere to respond to some questions throughout the presentation. And of course, we can always revisit if there are questions regarding the answers that you give on the Poll Everywhere questions in today's presentation. So as Chris mentioned, today I'll be presenting on cannabis use in palliative care. This is a really hot topic. I know it's very popular for us to talk about here in Iowa. And I heard that for those of you at AHPM last week, there was a lot of cannabis as well. So by the end of today's presentation, what I hope that you'll be able to do is be able to explain the pharmacokinetics and the pharmacodynamics of the cannabinoids within the human body, how it causes its benefits and its side effects, and also be able to discuss about how the pharmacokinetics of cannabinoids are affected by the route of administration, concurrent use with other medications, and changes in end organ function. And lastly, I hope that you'll be able to evaluate the literature regarding cannabinoid use in palliative care patients, specifically for symptom management of nausea and vomiting, anorexia, cachexia, pain, and sleep. Now, just to make sure everyone's Poll Everywhere is working, here's a practice question for us. So what does SPPCP stand for? Is it A, Society of Pain and Palliative Care Providers? Is it B, Society of Pain and Palliative Care Pharmacists? Is it C, System of Pain and Palliative Care Practitioners? Or is it D, Sect of Proactive Prescribing Cool Pharmacists? Let's see, I see 10 results and 19 participants. So let's just see what we have here. All right. Well, the right answer is Society of Pain and Palliative Care Pharmacists, though I do have to say Sect of Proactive Prescribing Cool Pharmacists sounds pretty cool too. But if you're having issues with Poll Everywhere, feel free to send a message through the chat, and I would be happy to help you troubleshoot, or also Chris would be happy to help you troubleshoot. But I'm going to continue on with the presentation at this point. So to start off with, I want to talk a little bit about the background of cannabinoids. What are they? Where do they come from? So to start off with, there are three different classes of cannabinoids. We have our endocannabinoids, our phytocannabinoids, and our synthetic cannabinoids. Our endocannabinoids are these natural fatty acids that our body produces normally within the human body. And there are two major endocannabinoids, 2-AG and anandamide. Then we have our phytocannabinoids, which are the ones that a lot of people know about. The phytocannabinoids are derived from the cannabis plant, also the hemp plant, and it's typically the oil resins that we use. And the two most well-known phytocannabinoids are cannabidiol, or CBD, and also tetrahydrocannabinol, which is THC. And then lastly, as pharmacists, we get a lot of exposure with synthetic cannabinoids, which are analogs typically of phytocannabinoids that are manufactured in the laboratories. And two major examples are dronabinol, also known as Marinol or Syndrose, which is a synthetic THC compound, and then nemabolone, which is a synthetic cannabinoid THC analog. Interestingly enough, nemabolone is different enough in chemical structure from THC that actually does not show up on your drug screens for THC. In terms of what cannabinoid products are available in the market right now, there are 5 different products available that I've shown here, and I'm not going to go too in depth in these materials. One of the products that I have listed here is currently not FDA approved and not available in the United States, but has been undergoing a lot of research within the United States and outside the United States, and is approved within the UK at this time for MS spasticity. Now, as pharmacists, I feel like we always want to know, how do cannabinoids work in our body? So one of the things to think about is, how does cannabinoids produce its therapeutic effects and its adverse effects? Now, cannabinoids are well known to act on the central nervous system, specifically to cause euphoria, to alleviate anxiety, to cause changes in neuronal plasticity. And I'm sure that you've heard of this either in the news or from patients or from your providers, but also to provide benefit for pain. Now, THC and CBD act a little bit differently in the CNS. Euphoria is typically caused by THC. CBD does not have as much euphoric effects, but otherwise, both THC and CBD can alleviate anxiety, cause neuronal plasticity changes, and provide benefit for pain. Cannabinoids can also act on the cardiovascular system to cause hypotension and arrhythmia. And it can also act on the GI tract as well, to decrease satiety and to also decrease GI motility. In fact, some people argue that the nausea and vomiting side effects that patients experience with cannabinoids is due to this decrease in GI motility. And the actions within these three systems is mediated through THC and CBD's activity at the cannabinoid receptor type 1 or CB1 receptor. Interestingly enough, at this receptor, CBD has a negative modulating effect on THC activity at this receptor. And some people argue that when you take THC and CBD together, CBD can actually mitigate some of the adverse effects caused by THC that when acted upon by the CB1 receptor, or acted upon on the CB1 receptor. My apologies. Other activities that cannabinoids have also include activity within the immune system. It is thought that cannabinoids can help suppress or otherwise modulate the immune activity within the full body and also in the GI tract, which is where some people hypothesize that we can use cannabinoids to help with some of the symptoms that patients with inflammatory bowel disease experience. Cannabinoids can also act on microglia, specifically in the bone, to help with bone homeostasis, which is where some people have the hypothesis that cannabinoids can help with osteoporosis. And the activity within these two systems is mediated by the cannabinoid receptor type 1 or CB2. And both THC and CBD act on the CB2 receptor. Again, more activity of the cannabinoids also occurs in both the central and the peripheral nervous system and can actually induce hyperalgesia and also help with regulation of heat or otherwise thermoregulation within the body. And the mechanism behind this is not well known, but it's postulated to be due to activity at the transient receptor potential of vanilloid 1 or TRPV1. And for those of you familiar with capsaicin, will also recognize that this is the receptor that capsaicin acts upon, and both THC and CBD are hypothesized to act on this receptor as well. Lastly, cannabinoids are believed to have some role in energy homeostasis and metabolism within the body. However, the mechanism behind this is relatively unknown. Still, it is believed that it is due to some sort of synergistic activity within the brain and in the GI tract, and it is believed that it is the G protein coupled receptor 55 or GPR55 that mediates the activity of cannabinoids for energy homeostasis and metabolism. And it is argued that this activity may be due to only CBD, which is interesting as we talk about the literature and the evidence regarding THC and CBD use later in today's presentation. So just as a really quick review, so what is the pharmacodynamic activity of CBD and THC at the CB1 receptor? We have A is CBD potentiates the therapeutic effects of THC. And then we have B, CBD reduces the therapeutic effects of THC. And then we have C, CBD potentiates the adverse effects of THC. And then we have D, CBD mitigates the adverse effects of THC. Well, that was interesting. I had 10 results and then jumped down to 7. All right, let's see what people are thinking. So for those of you that answered D, CBD mitigates the adverse effects of THC at the CB1 receptor, that is correct. I see some people chose CBD potentiates the therapeutic effects of THC, or CBD reduces the therapeutic effects of THC. There is no research at this time on whether or not CBD potentiates or otherwise reduces the therapeutic effects of THC, but there is research being done on CBD's activities to mitigate the adverse effects of THC. All right. So thank you for answering that question. Moving on. Now that we know a little bit about the mechanism of action of cannabinoids, let's talk a little bit about the pharmacokinetics. Now, absorption of cannabinoids is highly variable depending on the route of administration, and there is a huge variety of different routes in which cannabinoids can be administered or taken. And I will start off with the most common and the cheapest route of administration, which is inhalation. Now, this is a very popular route of administration, especially for recreational users, mostly because the time of onset of its effects are within seconds. So for those that are looking for really fast effects, inhalation route is the best route, and it has a Tmax of 30 minutes on average, and the duration of effects is about 2 to 4 hours, which is on the shorter end of the options available for us in terms of route of administration. Interestingly enough, this route also has the highest bioavailability, mostly due to the fact that cannabinoids exist in an acid form that has to be decarboxylated in order to be released and absorbed by the human body. And one of the best and easiest ways of causing decarboxylation of these acid forms is to use heat. So if you think about it, when you're smoking, as most people do, you're heating it up. Now, of course, cannabis smoke has been shown to cause irritation of the airways and can lead to bronchial inflammation and cough. Now, there is limited evidence at this time on whether or not the inhalation route will contribute to lung cancer at this time, so I can't really say safety-wise whether or not that is a concern. However, some people argue that you could use vaping instead because you aren't inhaling smoke, and that is technically less irritating than smoking cannabis. What is also interesting to note is that for long-term users of cannabis through the inhalation route, they might actually have increased exposure because inhalation technique actually affects the amount that patients are able to absorb. For those that are able to have efficient technique, which is like inhaling in slowly and deeply and then holding your breath and then slowly releasing it, may actually have increased exposure and absorption than users that are not as efficient with breathing in, holding their breath, and releasing it slowly. So something to note. Another common route is the sublingual and buccal route. Time of onset is relatively quick at 5 to 15 minutes, not as fast as the inhaled route, but still faster than the other routes we will talk about. Time to peak concentrations is an average of 4 hours for THC. I could not find data regarding CBD. Duration of effect is still unknown. This route of administration is becoming more popular, but there's not a lot of data in regards to it. In terms of bioavailability, people argue that it is less than the inhalation route, but is greater than the oral route, mostly due to its ability to bypass the first pass metabolism due to the liver. Another route that I included in today's presentation is the transcutaneous route, and I included it because it is a route that I commonly get asked about as cannabinoid topicals and creams become more popular. There is unfortunately a significant lack of research regarding the pharmacokinetics of this route in cannabinoids. There is study on bioavailability of THC and CBD in cell cultures. So take that information with a little grain of salt. Some people argue in that study, and it was a single study that I found, that CBD may have greater penetration of skin cells than THC in terms of transcutaneous route. And the last route I will talk about is the oral route, which is another very common route. Now, this route has the longest time of onset of action. So if you have patients that are taking cannabinoids that have previously used the inhaled route, they might find this route to be not as rewarding because it takes so long for the effects to onset, with a time of like peak concentrations of 4 to 6 hours. The benefit of this route, though, is that the duration of effect is quite long, with a minimum duration of effect of 8 hours, and can go up to, I saw, 22 hours, though it's extremely variable depending on the patient's specific factors that are involved. However, this route has the lowest bioavailability. Remember, I talked about earlier in the presentation how the acid forms of cannabinoids have to be decarboxylated, and there's not a lot of decarboxylation of the acid forms within the GI tract, so the bioavailability is quite low. Now, one thing to note with this route, because of the time of onset, this route has a very high risk of unintentional excessive ingestion. What happens is that patients will take a dose and they don't feel an effect, so they take another dose, don't feel effect, take another dose, and then by the time the effect actually hits, they've taken more than what they intended to take. And that's just something that you want to be aware of when starting patients off on an oral regimen, or if patients decide that they want to start using oral cannabinoids. In terms of distribution, cannabinoids are highly protein bound, 90% protein bound, and typically distribute to highly vascularized areas of the body, which are the lungs, the heart, the liver, and the brain. And the volume of distribution is relatively high. You'll notice there's a difference between CBD and THC in what I was able to find in terms of data. But do note that both CBD and THC are extremely lipophilic. There is evidence showing that THC can cross the placenta and is excreted into breast milk as well. Cannabinoids are primarily metabolized by the liver, and they are metabolized by CYP enzymes, but THC and CBD are metabolized differently. THC is metabolized predominantly by CYP2C9 and CYP3A4 into an active metabolite, 11-hydroxyl-THC. Now, this active metabolite is twice as potent and has twice as long of a half-life as the parent THC compound, and undergoes glucuronidation into inactive metabolites. CBD is argued to be safer because not only does it not have the euphoric effects of THC, but it also does not metabolize into active metabolite. CBD is metabolized primarily by CYP2C19 and CYP3A4 into inactive metabolites. Now, because THC and CBD are metabolized by CYP enzymes, they are subject to a lot of drug-drug interactions. So unsurprisingly, if cannabinoids are concurrently used with CYP inhibitors, such as grapefruit, your azole, antifungals, clarithromycin, amiodarone, and HIV antivirals, it may increase serum cannabinoid levels. Whether or not that produces a clinical effect is extremely variable, but it's just something that you'll want to be aware of. Same thing if cannabinoids are used concurrently with CYP inducers such as rifampin, carbamazepine, St. John's worts, and barbiturates, and other medications used for seizures as well. And not only are cannabinoids affected by CYP inhibitors and CYP inducers, but they themselves can actually affect activity of CYP enzymes. Cannabinoids have been shown to induce CYP1A2 activity and maybe CYP2B6. Now, of note, smoking tobacco can induce CYP1A2 activity, and smoking cannabinoids have also been shown to induce CYP1A2 activity independent of cannabinoid induction of CYP1A2. So if you have a patient that is smoking cannabinoids, you have basically 2 times the induction of CYP1A2 activity that you would want patients to be aware of, or you yourself would want to be aware of. And medications that are affected or are metabolized by CYP1A2 and CYP2B6 that you may want to be on the lookout for are medications used for pain, medications used for nausea and vomiting, also birth control, and also other medications such as haloperidol. These medications may be less effective when used concurrently with a patient using cannabinoids. Enzymes that are inhibited by cannabinoids include CYP2C8, CYP2C9, CYP2C19, and some of the other liver enzymes involved in glucuronidation. And medications that you'll want to watch out for in terms of potentially increased risk of adverse effects due to increased serum concentrations when used with cannabinoids are medications typically used in patients for mood, for GERD, for pain, for anxiety or depression, for cholesterol, and also for diabetes. And an interesting thing that I found was that THC and CBD may increase serum warfarin levels. Now, the mechanism behind this interaction is not well known, but it's hypothesized to be due to CYP inhibition and also maybe displacement of warfarin at protein binding sites. But there have been case reports of patients that were well controlled on warfarin that were then started on THC or CBD that then caused warfarin levels to increase. And it is thought that it's because of the cannabinoids. Now, cannabinoids are excreted through both urine and feces. I will say that it is excreted more in the feces with 5% unchanged drug, but there is renal elimination as well. And the half-life of cannabinoids depends on which cannabinoid we're talking about and also how long and how frequently a patient is using it. So THC has a half-life of 22 hours, and then CBD, for those users that are using it intermittently and not as frequently and not heavily, have a half-life of 24 to 31 hours. However, if patients are heavy users or frequent users, they will have a much longer half-life, mostly because this compound is extremely lipophilic and partitions into the adipose tissue. So again, you will have that sort of delayed sort of half-life going on. Now, just to review what we recently talked about, what concurrent use of cannabinoids and warfarin will most likely result in what change in a patient's INR. We have A, patient may experience an increased INR. We have B, patient may have a decreased INR. We have C, patient will experience no change in INR. Or we have D, we may have unreliable INR interpretation. All right, let's see what people are thinking about show results. Increased INR. So it looks like a lot of people chose increased INR, which is the correct answer. Remember that when we use cannabinoids with warfarin, we will get increased serum warfarin levels, which will most likely increase INR. For those of you answered unreliable INR interpretation, now that I think about it, I do not know whether or not INR is a reliable measure in a patient that use cannabinoids with warfarin. A very interesting food for thought for me to think about. And if you have questions at the end of the presentation, I'm happy to discuss this with you. All right, let me continue on with the presentation. Thank you for those of you that answered this question. Another question I want to pose to see what you guys think, and this is a more challenging question, is which of the following patients is at the highest risk of dose-related adverse effects of cannabinoids? We have A, a 35-year-old man with cirrhosis, now status post-liver transplant on tacrolimus, mycophenolate, and prophylactic Truvada. Then we have B, a 75-year-old woman with CKD, type 2 diabetes, and vaginal candidiasis on fluconazole and gabapentin. Then we have C, a 62-year-old woman with AFib and breast cancer on amiodarone and tamoxifen. And then we have D, a 24-year-old woman with fibromyalgia on duloxetine and amitriptyline. I'm going to wait to see if we can get 10 respondents. All right, I think that is the respondents are going to get. So let's see what people think. Interesting. Okay. All right. So for our 35-year-old man with cirrhosis, status post-liver transplant, we had a lot of people answer for that. Typically, patients that have cirrhosis that are now status post-liver transplant have a return of liver function as well. So if you're thinking about the patients would be at increased risk of dose-related adverse effects of cannabinoids due to decreased hepatic function, this is not a likely candidate to experience that. It is true that ritonavir is an inhibitor of CYP3A4 and can cause elevated serum concentration levels of cannabinoids. Tacrolimus and mycophenolate don't really interact as much with cannabinoids. For those of you that chose the 62-year-old woman with AFib and breast cancer on amiodarone and tamoxifen, I imagine you guys are also thinking about how amiodarone is a CYP3A4 inhibitor, and it is causing increased serum concentrations of cannabinoids, and therefore leading to increased risk of adverse effects. Nobody chose the 24-year-old woman, and nobody chose the 75-year-old woman with CKD, type 2 diabetes, and vaginal candidiasis, which was the right answer. It is the right answer that I put mostly because the patient's on fluconazole, which is a potent inhibitor, CYP inhibitor. And not only that, but as patients get older, their CYP function deteriorates. And not only that, but the patient also has CKD, which decreases elimination of cannabinoids and their metabolites in the body as well. I am happy to discuss this more at the end of the presentation. For those of you that answered, thank you so much for participating, and I'm going to continue on with the presentation. Now let's talk about cannabinoids in palliative care. And one of the reasons why I want to talk about cannabinoids in palliative care is that a lot of providers that I work with are very interested in this. In a 2018 national survey of palliative care providers, 70% of the respondents actually believe that cannabis would be helpful at end-of-life care. And what they thought would be extremely helpful to use cannabis for would be nausea, appetite, pain, and sleep, which are the major symptoms that we'll talk about later in this presentation. They also thought that cannabis would be helpful for irritability, emotional suffering, and agitation. Now, in terms of the evidence behind cannabinoids for these symptoms, there was a 2017 report published by the National Academies of Science, formerly known as the Institute of Medicine, and they did a comprehensive literature review of the general population using cannabinoids, and what they reported is that there is strong evidence for the use of cannabinoids for chronic pain, chemotherapy-induced nausea and vomiting, and then MS spasticity. They also said that there was moderate evidence for short-term sleep outcomes, but only for patients with obstructive sleep apnea, with MS spasticity, with chronic pain, and with fibromyalgia. And there weren't really short-term sleep benefits for other patient populations. They also said that there was limited evidence for HIV, AIDS-related appetite and weight loss, Tourette syndrome, anxiety symptoms for patients experiencing social anxiety disorder as measured by a public speaking test, and then symptoms related to PTSD. They also said in their report that cannabinoids were most likely ineffective for dementia, glaucoma, and depressive symptoms related to chronic pain or MS. And then there was a very, very long list of other indications that the National Academies of Science felt that cannabinoids, there wasn't enough data to make a conclusive statement on whether or not it was helpful or ineffective for these indications. But what does that really mean for our palliative patients? In order to figure that out, what I did was I went back to the primary literature and looked specifically at the studies that looked at palliative care patients. And this is what I found. In terms of nausea and vomiting, there are several studies. Out of all the symptoms, this is actually the symptom that was the most well studied in palliative care patients. In cancer patients, there were two major studies that I found. One looked at using dronabinol and compared it to placebo for about 22 days. And you'll notice that's a relatively small study. And they started patients off at 2.5 milligrams a day, and patients could titrate up to 20 milligrams a day over that 22 period. And what they actually found was that patients on the placebo did better than patients on dronabinol. Patients that were using dronabinol actually had worsening of their nausea and vomiting. In a separate study in cancer patients looking at a THC and CBD compound that was also placebo-controlled, they found similar results. And this was the oral mucosal spray, and patients could use up to 48 sprays a day. Patients in this study also had reported worsening of nausea and more episodes of emesis. In AIDS patients, there were different results for a study that used dronabinol. Again, they compared it with placebo over a 6-week period, but they started patients off at 2.5 milligrams BID, and they kept patients at that dose. And they reported that patients on dronabinol actually had had improvement in their nausea and vomiting versus patients on placebo. So what I concluded from this evidence is that cannabinoids may not alleviate nausea and vomiting and may in fact exacerbate the symptom in palliative care patients. Other studies looking at cannabinoids for nausea and vomiting in other patient populations have also suggested that cannabinoids may not be your best choice first line for nausea and vomiting. And there are some people that argue that there actually might be a very narrow therapeutic window for cannabinoids when used for nausea and vomiting. Remember how I talked about earlier in the presentation about how cannabinoids can decrease GI motility, which some researchers argue is the mechanism contributing to nausea and vomiting side effects with cannabinoids. What about for anorexia and cachexia? Now, in order to look at anorexia and cachexia, I looked at different dimensions of it. So to start off with, I looked at weight gain. I found this study in cancer patients where they looked at dronabinol, and they actually compared it to an active treatment. They used megestrol or Megace, and they looked over 57 and 80 days. They started low dose and kept patients at low dose. And they found that patients that were on dronabinol did gain weight, but not as much as patients that were on Megace. In AIDS and HIV, though, they found there was a lot of conflicting evidence. So there are 3 studies here. One of the studies compared it to megestrol, whereas 2 of the other studies compared it to placebo. And these studies, between the 3 of them, looked at a 3 to 12-week period. And you'll notice that when compared with placebo, it looked like in one study there was benefit, but in another study it was not statistically significant in comparison to placebo. In the one study that compared dronabinol to megestrol, they found that megestrol, again, was more effective in terms of statistically significant weight gain in these patients. And then there is one study looking at patients with Alzheimer's, and they did a crossover placebo control study over a 6-week period with dronabinol. And they found that dronabinol was more beneficial than placebo. But again, they did not compare this with other agents that you could use to help with weight gain in patients. And then in terms of caloric intake, there were several studies that looked at whether or not cannabinoids can help with caloric intake. One study in cancer patients looked at dronabinol, again compared it with placebo over a short period of time. And they found that dronabinol was better than placebo for increasing caloric intake, looking at statistically significant differences. And then in Alzheimer's patients, again with dronabinol, they found that placebo there was no statistically significant difference with dronabinol compared to placebo in terms of changes in caloric intake for patients with Alzheimer's. In terms of appetite, there are a lot more studies with cancer patients looking at dronabinol, THC, or THC and a CBD compound over a variety of study periods. Most of the studies compared to placebo, but there is one study that compared to megestrol. And for the studies that compared it to placebo, they found that either the cannabinoids had statistically significant improvement in appetite, or there was no statistically significant change. For the studies that compared the cannabinoids to megestrol, they found that megestrol did better or was better than the cannabinoid that was studied, or in this case, dronabinol. There was that study in AIDS patients where they looked at changes in appetite and they compared it to placebo. Again, they found that dronabinol was statistically significant in comparison to placebo for appetite stimulation. Overall, what I concluded in terms of efficacy for cannabinoids for anorexia and cachexia and palliative care patients is that it may help with anorexia. They may not be as effective as megestrol. And something to note is that these studies reported that the weight gain with cannabinoids was mostly due to adipose tissue and not really lean muscle mass. Interesting enough, I couldn't find any studies comparing cannabinoids to mirtazapine, which is the agent that I see most commonly used by our palliative care service here for appetite stimulation. It would be interesting if someone did a comparative study with that. Now, in terms of pain, I'm going to only cover cancer-related pain because that's a huge topic to talk about. And in the studies that I found, they only looked at the THC CBD oral mucosal spray and this was mostly done in patient populations outside in the United States, and they only compared it to placebo. And they found that the cannabinoid product was statistically significant, resulted in statistically significant improvement in pain compared to placebo, but only in patients that were on opioid therapy. None of these studies reported whether or not these patients were using any other agents. They just said patients that had uncontrolled pain on opioid therapy. So what I could only really conclude from this study, from these two studies, is that we could use the oral mucosal THC CBD spray to help with cancer-related pain for patients that had uncontrolled pain on opioids. I could not tell you how cannabinoids compared to other agents that we use for pain in our palliative care patients. Now, in terms of sleep, one thing to note about the studies that I found for sleep was that sleep was not a primary endpoint or primary outcome in any of the studies that I'm going to talk about. Now, they looked predominantly at cancer patients in the studies that I found. And again, they compared cannabinoids to placebo, and they only did it for a relatively short period of time, no more than 9 weeks. What they found is that for two of the studies, the cannabinoid product resulted in statistically significant changes in patient satisfaction or patient reports regarding sleep quality. And then in one study, there was no statistically significant difference in comparison to placebo. So what I concluded from this is that cannabinoids may help improve sleep in palliative care patients with cancer, palliative care patients with other indications or diagnoses, not entirely sure about. Again, I just want to re-emphasize that in terms of the studies that I talked about, there are a lot of limitations with the studies in palliative care patients. For one thing, most of these studies only looked at a very short duration of time. So discussion of adverse side effects or safety of cannabinoids long-term in these patients, we really don't know. Also, a lot of these studies compared it to placebo instead of active treatments. So hard to say where cannabinoids fall in terms of first line, second line, third line, last line, or maybe not at all. Also, they looked at very small patient populations in these studies, and a lot of these studies reported statistical significance and did not talk about clinical significance in these studies. Now that you have heard a lot of what I've had to say about the evidence, how do you feel about potentially using cannabinoids for symptom management in your patients? And this is an open-ended response. It's going to generate a word cloud. For those of you that want to submit a response, for those of you that don't want to type in words, I've actually managed to successfully use emojis for the word cloud. So if you want to send an emoji in, go ahead. Somebody is sold, okay. All right, a lot of people are thinking I need to do a lot of monitoring. Okay, looks like somebody was able to successfully send in an emoji. It looks like somebody tried sending a different emoji but didn't show up. All right, well, we're getting close to the time I have allotted. So it looks like a lot of us are thinking about we need to monitor. I'm of the similar mindset. And then a lot of variety of feelings and opinions and thoughts regarding cannabinoids. And again, this is a very controversial topic. So for those of you that shared, thank you for sharing. This word cloud is very interesting to look at. So a quick review of what we talked about today. Cannabinoids act on the CB1, CB2, TRPV1, GPR55 receptors, and it can produce a very broad range of therapeutic and adverse effects. The pharmacokinetics of the cannabinoids are affected by a lot of different factors. These include route of administration, concurrent use of other drugs, and then hepatic and renal function. In terms of what the evidence say about cannabinoid use in palliative care patients, it shows that use with nausea and vomiting may not be a very good idea, questionable about whether or not we can use it for anorexia, cachexia, and that there may be benefit with use for pain and sleep. That is the end of what I prepared to present. Thank you for those of you who participated in the Poll Everywhere questions. I'm happy at this time to take whatever questions you have. So what questions do people have?
Dr. Koo, if you can look at your chat box, most people typically will post questions via the chat.
Let's see. Am I willing to email the slides? Yes. If you could email me at jennifer-koo@uiowa.edu requesting the slides, I'm happy to share them with you. Slides recording will be shared. Chris, have I been recorded?
Affirmative.
Okay, so recordings will be posted and they will be available through the PGY2 webinar section of the SPPCP website for those of you that are members. Otherwise, I'm not entirely sure how non-SPPCP members can access the recording. Let's see, if I were to recommend a formulation, which would I select? For an example, am I likely to select topical first? I will say that if I am using cannabinoids in a patient, and I would like to point out that in Iowa, there are legal limitations of using cannabinoids. In fact, the only products that we can use are oral, and those are FDA approved products. So that is what I would use. And if a patient requested a topical formulation, I would really be curious on what they're using it for. There's only evidence showing maybe potential benefit of topical products for eczema, but it's also hard to tell whether or not that is a placebo effect or not because they don't compare it to active comparators in the studies I've looked at. More often than not, most of my patients will use inhaled or oral route. If patients are doing medical cannabidiol or they're using the FDA approved products, it's going to be the oral route. For patients that are recreational users, it's going to be the inhaled route. I personally don't recommend a formulation. I just ask patients to make sure that they tell me what they're using so I can keep an eye on their drug-drug interactions and other things I need to monitor for in terms of the therapies that my providers are prescribing for. Let's see. All right, but excellent question. Other questions that people have at this time? You don't have to have questions right now. I'm happy to answer any questions you have later after this webinar is over. Well, Chris, I don't think I'm getting any more questions at this time.
It's because you did such a great job.
All right. Well, again, I want to thank everyone for listening in. And thank you for coming in. And I hoped that this was very educational for those of you that are here. And for those of you that emailed me requesting the slides, I will email you back. If you have questions later on after the presentation, definitely email me. I'm happy to answer any questions that you may have. But again, thank you for listening in. I hope that you have a great rest of the Friday and that you guys have an enjoyable weekend. And for those of you at APHA, I hope you enjoy the rest of your conference.
Thanks, we will. Thanks everyone for joining us. Have a great weekend. And thank you, Dr. Koo. It was a wonderful presentation.
Thank you so much for giving me the opportunity to present. Let's see.